joined us via the internet, you should be able to see the slide presentation on your screens when our guest shows them. The topic for this month's Community Connections is Hospice 101, and our guest today, joining us from the West Slope, is Brian Whitmore, Director of the Access Team for Hope West, Colorado. Now, Brian is a licensed clinical social worker and works with patients and families as they seek information and assistance for their loved ones during this time of life. Brian has prepared a few handouts for today's presentation, and we will make those available on our website following today's broadcast, along with a recording of this video as well. With that, I want to welcome Brian to Community Connections, and I will turn it over to you. Brian, they can see you, and I guess we didn't get a chance to work this out, folks, beforehand. Do you want to show your screen, and I can do that, or you want me to show your slideshow for you?
You know, it'd be great if you could pull it up and do that, because I'm having connectivity issues off and on.
All right, so why don't you introduce yourself while I get those slides queued up, okay?
Yep, like Todd said, I'm Brian Whitmore. I'm a licensed clinical social worker with Hope West. I've been here 16 years now and direct the admissions team. So today I just want to kind of talk about the referral process for Hope West. I know we serve Grand Junction, Montrose, Delta, so it could be a little different wherever you may be, but it works pretty much the same at most hospices. Talk about a referral process, open access, review the hospice benefit as far as how it's paid for, what services we provide, the different levels of care, and then kind of go over any questions, because I imagine if you've been doing, home care for a while, you've probably had people who've had a hospice. It's a good chance. So I'm going to click on to the next slide there, Todd. So people are referred by anyone. You didn't have to be a physician. We have a lot of families who call. We have a lot of walk-ins who come in and just kind of stop by our office or at our care center. We try to tell people it's easy to get into Hope West and not worry about the program exactly. We do have a few other programs besides hospice. So people phone, fax, we actually have an app. We make it as quick as possible to get out there. We're in people's, typically you can be out within 24 hours to all our referrals. We respond within an hour to those referrals that we get, at least by phone. So all we really need for a referral is a name and contact information. We don't need a lot of detail. Most hospices and Hope West, we have access to QHN out here, which is Quality Health Network. So we can go on to the community kind of EMR. We can go into St. Mary's EMR. So we have access to medical records, and our team will procure those from the physician offices. The only place we really need a physician order before we just walk in is, of course, the hospital. So we ask that, we do have people that have actually called from their room at the hospital asking about hospice. So we ask them to talk to the doctor there to put a referral in. Once we receive the referral, we follow up with the resident, family, physician, and whoever else is appropriate. If they have a home health provider, we try to talk to them as well. Okay, go to the next slide.
All right.
Let's see. And I think that, with different hospices, one reason I've been here 16 years is we have this open access philosophy at this, this hospice. So we take people into Hope West programs, regardless of their ability to pay. A lot of times it depends, we allow people to get a blood transfusions, which some hospices don't do. We have people who occasionally get radiation, chemo, tube feedings. So the sooner we can get people in, the more we can help these families with, their goals of care, their psychosocial issues, financial issues. We try to help in all those areas. So we have what's called a transitions program that we can bring people in for who aren't quite ready for hospice, or living with cancer program for those who are still getting treatment and still not ready for a hospice level of care. So we take all that into consideration. You can go ahead to the next slide. I think I kind of touched on this. The open access philosophy allows people more time to work on their MDPOAs, living wills, DNRs. We help with that. You don't even have to be in one of our programs, and we'll do that when we go out for a presentation with folks if they ask. We sometimes, depending on the pay source, sometimes the VA will pay for chemotherapy and hospice. So we'll go ahead and bring them into hospice and cover that. It works a lot with providing better communication with the physicians that they see, or if they're getting home health or therapies, we can help a lot with their goals of care, help navigate through that healthcare system. For a lot of people, when they're coming into Hope West, they have a lot of decisions to make, and they get a lot of information from all different sides. So we like to sit down and talk with a plan, help them formulate a plan. Sometimes it doesn't include us, and that's fine. Maybe they need, caregivers, in-home caregivers and therapy. We'd rather them get what they need than just have our service. We'd like to reduce the length of stay in the hospital setting. Our hospice transitions and Living with Cancer helps target keeping people out of the hospital if that's their goal. So currently, for example, I think we have 450 hospice patients today, and probably another 200 in our palliative care programs. And I can think there's only 2 or 3 that are actually in the hospital currently. So our goal is to respond to folks. We have nurses on call 24 hours a day that see patients in their home, no matter what program they're in. So next slide. Our services for hospice are covered by Medicare Part A, of course, Medicaid, private insurance plans, VA benefits, and we do some people who don't have insurance. We use a self-pay. We have a sliding scale for those folks. And if they still can't afford that, we have what we call grants. And, we have a lot of folks donate to hospice, and we'll see, we can do course services a lot of times. So that means visits from our staff, and we'll cover like a comfort kit for pain, nausea, those type of symptoms. We'll cover that for the patient and family. So at no cost to them. And another thing that a lot of people don't know is Medicaid allows what they call butterfly waiver for kids who are receiving treatment and maybe needing hospice level of care. So it allows that patient and that family to still seek curative care and have hospice, which is a nice thing to have available for folks. Next slide. See the hospice Medicare benefit, people have to elect that benefit. We have to certify with our physician that the patient is eligible for services, as well as their primary care physician. They provide 2 90-day benefit periods under Medicare, and then unlimited number of 60-day benefit periods. So we have to recertify that. So continually. That's why we end up with people in hospice maybe for a year or 2, or maybe they bounce from hospice to a palliative care program, decline again, and back in hospice. So we have, in that benefit period allows for different levels of care. So there's routine home care, which obviously is in the home or nursing home or assisted living. We have what's called respite care. Obviously, people can go into a nursing home or our facility, and we get reimbursed at a different rate to cover respite care. We have general inpatient level of care, which allows people to go typically to our care center for a few days to get symptoms managed that maybe they can't get under control at home, or they have a caregiver breakdown. It allows folks, we have contracts with our hospitals here in town where we can provide general inpatient level of care at area hospitals as well. And a few of the nursing homes, we can do that. That's how we get reimbursed. So, next slide. Okay, the patient must choose to come into hospice, which is a big thing. People think, I'm just going to write the order and they're going to be in hospice. Well, the physicians have to understand we have to, either the patient or their medical power of attorney or proxy or guardian has to sign them in. You just can't write an order and have them be in hospice. And like I said, for Medicare, which is 95% of our patients, they have to have Medicare Part A. That's what covers hospice. Next slide. well, like I said, I kind of covered that, I guess, already. That we recertify every 90 days, and then every 60 days for an unlimited amount of periods. So we do, if a patient is in and out of hospice through these benefit periods, we do have to have a physician face-to-face visit starting on the third or greater benefit period before they come back into hospice. So we have patients, for example, who are here for, say, 3 benefit periods, and they go to Arizona for the winter and get admitted into a hospice there, and they discharge and come back, and now they're in their 4th or 5th benefit period. We have to have a doctor go visit them to make sure they're still eligible. So, go ahead and use the next. The team, the interdisciplinary team, of course, is the nurse, social worker, CNA, chaplain, and the physician here at Hope West. We have a lot of volunteers who help out as well. They're part of the team. We have upwards of 1,500 volunteers that help with anywhere from, patient care to events to working in a couple of our stores that we have. The benefit includes medications related to the hospice diagnosis. Any equipment that patient would need, we have to provide through that benefit, as well as any medical supplies that are needed. And that's pretty much true for Medicare, Medicaid, VA benefits cover hospice as well. And most private insurances mimic at this point the hospice benefit through Medicare. Again, I kind of went through the levels of care. The routine home care is any day someone's in hospice. It doesn't have to be at home. So it's wherever they call their home. The respite care, which is a huge benefit. Medicare allows for five days of respite care for that caregiver. Medicaid allows 30 days a year. So Medicare is a unlimited number of five-day stays. But they won't let you just do respite care and then back home and then back into respite care. They don't see that as a good plan. Same thing with general inpatient care. Once that patient's symptoms or crisis is over, then we need to have a better plan in place and getting the patient back to their home setting. Typically 3 to 4 days in our care center is the average length of stay. We've had some people there longer, but like I said, 3 to 4 days is pretty much it. And that is the down and dirty 101 on hospice. I figure you guys have more questions than I can hit, so I figured I'd go over the key points.
That's great. And by the way, Brian, it's really good to see that you actually have a face. We've been just communicating email, and that it's nice to see that you're actually free and human. So folks, you know how this works. Those who attend regularly, you can send your questions in the chat box there, and I'll feed them to Brian for. We already have like 4 or 5 that were coming in during the time. So I'm just going to work through them in no particular order. Are you ready for that, Brian? Sure. Can hospice patients receive curative care also?
Yes, sort of. So that's where it kind of depends. Medicare will not cover curative care. So a lot of times, especially oncology patients, cancer patients are one we get often, who the oncologists will say, well, it's not curative, it's palliative care.
Okay.
Well, we don't see through the same lens as far as what's curative, what's palliative. So we kind of have to sort that out. And sometimes if people have, let's say, a chemotherapy that's been ordered that, is clearly curative in nature, but they already have it in hand, like let's say an oral chemo, we'll bring that person into hospice and go ahead and see, okay, well, the next 30 days, is that something they're going to continue? Or blood transfusions. We have people with blood transfusions, and maybe might not be curative, but they're definitely life prolonging. And so how many of these are we going to do? What's the plan? Is it once a month? Well, yes, we'll cover that. Is it twice a week? Probably not going to go ahead and bring them into hospice. Like I said, though, the VA sometimes will say, we know it's curative or life prolonging, but we'd like them to have hospice levels of care, and we'll pay for both. We'll pay for hospice and the chemo and the blood transfusions. So there is a yes, I would say, for our hospice. I can't speak to all hospices. Some will not admit somebody who's getting blood transfusions.
Oh, okay.
So, yeah, and some won't touch folks who are getting a chemo or radiation. But we do. That's we kind of work through it, see what we can do.
But you're saying it varies from hospice to hospice.
It does. It varies greatly.
Onto the radar screen for me, to be honest with you, 2 years ago when my brother died of cancer, and it was one of these things where I'm in healthcare, but yet I didn't know how hospice interfaced until we were sort of walking through it. You know what I mean?
Right.
And so he was receiving treatments, but I didn't realize that there's ambiguity about whether a hospice would take someone that's receiving chemo or not. So.
It is, because some of the ambiguities is some of those treatments are very expensive, and they can be 100 times what we get paid to care for someone. So out of that per diem per day, we have to cover, like I was saying earlier, our care, equipment, medications. So if that medication is related to their disease for hospice, then we're expected by Medicare to pay for that. So it would not allow us to see many patients.
No, understood.
Yeah.
Another question came. I said, I noticed on one of the slides that it said room and board are not included. So for our lower income clients, what options are there to assist them in that regard?
So at a nursing home or at let's say an assisted living, obviously Medicaid will cover room and board for patients, while hospice gets paid by Medicare typically, if they have that. So I'd say here we have the home community-based services program. And so for someone who's in assisted living, sometimes that money can be used for the room and board. So at assisted living. At the nursing homes, of course, they use they take the Social Security first, and then Medicaid covers the rest of their room and board.
Okay.
If they qualify. If they don't qualify for Medicaid, it's private pay for their room and board. Okay.
Another question that came in, and by the way, folks, those of you that are submitting the questions, thank you. And if you don't feel that I guided Brian well to the answer, or Brian answered, by all means, shoot me a text, and I'll be happy to get him to clarify. We won't let him off the hook just by spouting things off to us. Now, another one that came in said, you said private insurance. Now, the question is it standard on most insurance policies, or is it something you need to check and add, hospice care?
It varies, and there's great. Here we have Rocky Mountain HMO. It mimics the Medicare benefit. We have some insurances have a cap, so they'll say, hey, you have $3,000 or for hospice care, and we won't cover, this treatment, this transportation. So you really have to look at the insurance program, the policy, and see what it is. And there can be some, I assume, that don't have a plan. I haven't seen that, but I mean, basically $3,000 is close to not having a plan.
Yeah.
So have a $3,000 cap.
Well, I think the takeaway here, folks, or to whoever asked that question, the takeaway there is check with your insurance broker, find out what the standard averages are, and make sure your policy has it. Correct?
Oh, correct. Yeah, you'd want to check that. I think with anything, not just hospice.
Yeah. No, fair enough. This is a plug to check your insurance policy, just in general. Let's see, another question came in. We're a Class B medical company, a non-medical company. So we do a lot of ancillary things that could be helpful here. Do you have formal partnerships with companies like ours, or is it like you bring your own sort of, I'm assuming, and if I'm wrong in this question, please clarify it for me, folks. Like we do things like basic housekeeping and things like that around meals, whatever. And is that something that your company provides, or you partner with companies like ours?
Our CNAs will do that. And we also, I don't know if we partner, but we coordinate plan of care. If someone's already involved, or the family needs additional help, then we give them a a list of providers. We don't currently have any contracts with any.
Right.
Okay.
All right.
But we try to coordinate, and if we're not, if you're in Grand Junction, Montrose, and we're not coordinating, let someone know. I think it's so important, and you know, our CNAs are our biggest source of information about a lot of our patients and families and what they're really going through, and I think that's true with anyone's in the home for any length of time.
Sure.
I think there should be a log in the home and some type of coordination of who's doing what. So, and if we're not doing it, or whatever, wherever you are, and their providers aren't doing, their hospices aren't, I would ask them to.
Well, and again, not only keeping the patient in the middle of this discussion, right, to make sure that all the right services are being provided, rightfully so, and then also on the other side of it, right, we don't want to be duplicating services unnecessarily and things like that. So
exactly.
You know, this one I'm a little excited about asking you. Obviously, you're aware that the medical aid in dying statute passed in Colorado, and how has that impacted hospice and what you do?
You know, that question comes up a lot when I'm out doing presentations. So our physicians aren't going to be participating in writing the scripts for the medication. What we want to do is be an educator for patients and families who ask about it and kind of guide people the right direction.
Sure.
It doesn't mean we won't take patients who are interested in the right to die. If they have the medications and they're in our program, we will, we let us know when they take the medications. We'll provide still education, we'll provide postmortem care, but we will not be present when someone is actively taking the medications. So yeah, it's a great question. And currently on the Western Slope, I don't know of many providers that are participating. So it is going to be a challenge to find physicians who will help patients and families.
No, and I think it's equally true on the Front Range here as well. There's a instance right now here in Aurora where our main office is, where someone's seeking medical aid and it's not happening. But most places I know are opting out in various ways.
Most hospices will for a while. I know in Oregon and Washington, there are a growing number of hospices where the physicians don't still take a role, but the hospice teams are taking more of a more of being present and making sure people are taking the medications right, because there have also been several cases as the medication used for this has been in short supply.
Right.
Physicians and groups are coming up with, people are taking it and it's not working. And then people are in hospice in a coma for a few days after they've taken the medication. So we have that to plan as well. So we're still in the process of finishing up our policy and then educating the public. Yeah. No, that's a good question.
Yep. There's another one here regarding the Death and Dying Act. So we're going to stay on this one. Regarding the Death and Dying Act, can our caregivers be in the home or provide medication on the IHSS program? Actually, that's probably not a Brian question. It's probably a company question. But I'm going to let Brian speak for us so we can hold him accountable. No,
I'll just say no to protect you.
At this stage of the game, while People Care has not formulated its formal policy, right now our caregivers are not to be involved in the medical aid and dying process at this stage of the game until we formalize our own policy and consult with our legal department and everything else that's necessary to put us in the right position. So to answer that question, our current policy is no. We are not part of the process. Any other questions for Brian here as we start winding down? Looking for a few more. This person said, there was a slide that showed the average stay. It shows 30 days, 60 days, like 90 days. What is your experience of the average time that you're in a home from when you're called in to when the person dies?
So that's a good question. So I'll tell you this, 25% of the patients we admit, so we admitted, I think Junction 100 patients last month. 25% of those died within 7 days of admission to hospice. The average length of stay, though, is in that 120 day range right now. Yeah, we have, and most of those are folks who we're seeing a lot more dementia, or what we used to call general clinical decline, just no real specific disease. I think like most of us will have multiple health issues, or need more and more in-home care earlier. Those folks are with us, in that 120 day range. That window. In the average.
Okay. This one, let's see. What's your experience with insurance as far as continuing providing the benefit if the patient survives past a benefit period?
So with private insurance or Medicare, I guess would be the.
Let's speak to that person that posted. Is it private? You talking about private insurance or Medicare? Both.
Both. So Medicare is pretty good, as long as they're physicians or we have to do that recertification at those into those benefit periods. Yeah. We did run into, sometimes, if people are with us more than 6 months, they'll sometimes ask us to submit more information about the patient and withhold payment. But I can't think of, since I've been here 16 years, I think we've, proven that the person needed to be in hospice in probably out of the 150, probably all but 3 or 4 of them, to Medicare satisfaction. With private insurance, it can be a little more tricky because the patient does have to, pay their insurance, and they hit their deductible, and, they have to start that over in January typically. We do have a sliding scale, though, for people whose insurance has, if they've used up their $3,000, we do a sliding scale with them based off their income. And for our other programs, I will say for like transitions and living with cancer, where a lot of insurances don't cover the palliative care programs as often. So we'll do a sliding scale, and the typical rate is, around $50 a month for services for those patients. We don't run into many people anymore without insurance for hospice. So in the past we did, but not so much anymore.
Another question here. This person has been doing some research on your website, and it says the number of volunteers with the organization is quite impressive. Are people drawn to helping support hospice care, or why the large volunteer rate?
Oh, it's all the free parties we have for them.
Exactly. Which insurance covers.
Yeah. I think people are drawn. I think we're a pretty large organization here in Grand Junction, and so I think we've usually personal experience is the reason most people come to volunteer, and so some do, like I said, direct patient care. Some spend time we have a couple of stores in town that we have heirlooms, which is kind of like a high-end thrift shop. We have restaurants. So we give opportunities for people to volunteer in other areas, but mostly personal experience is why they come and want to give back time. So.
Okay. I tell you, the questions keep coming. So again, this is obviously a hot topic for us. Mm-hmm. And again, as I shared a brief intro to my story, like only because I actually experienced it alongside with a loved one, suddenly it's on my radar, Mm-hmm. This one says, there was a hospice agency that came actually to the hospital that my loved one was in and worked along with that floor staff. Is that something all hospice agencies do, or is that unique?
It's more common now. We have contracts with hospitals here to provide care. Like I said, we can't no hands-on care. We don't have that type, but our nurses can come and talk about symptom management, help the floor staff and the family, do education. The social workers can go up there, chaplains, that type of support. We used to do the GIP level, what we called like a direct admit into the hospital, and that person would be on hospice, but we haven't needed to do that as often with the care center and the addition of a lot of hospices or hospitals have started palliative care programs of their own inside the hospital, and they'll do a lot of the symptom management and end-of-life care and education there with the families. But we're still entrenched in St. Mary's and Community Hospital.
Yeah. Well, sort of along that same line, another question here, and I'm sorry, I'm skipping over because they sort of go together, folks. I'll get to yours though. Does hospice educate on overcoming the discomfort that so many people experience when dealing with dying? And I think behind that question is we're sort of a culture that has put off dying, and there was literally my grandmother died in my living room kind of thing when I was a kid. But then now it's sort of we push it away. How does Hope West work with people to? I think the question here is not to become comfortable with dying, but at least be able to come.
Maybe hospice services or just
exactly.
Well, that's kind of two parts. We do a lot of education with our providers in town, and we stress to them because they do have, even our providers, our physicians have trouble, not our physicians, but physicians in town, trouble talking about death and dying with their patients. And so they're like, well, I'm reluctant to mention hospice. I don't want to scare them. We changed our name to Hope West. We took the word hospice out of it. And we have other programs. And, we try to approach the physician groups and other providers about just getting the service. What's the in-home care the person needs, and let us talk to them about what program matches what they need, and try to take that stigma away. I don't know if we can ever get past the death and dying stigma sometimes in our society. I have noticed a change with younger physicians. I do a lot of the education with the residents at St. Mary's, and they seem to be more on top of palliative care and referring to hospice sooner, and more comfortable with it. And as far as patients and families go, I think it's the same thing. We find, we talk about the services themselves, not so much the death and dying, and focus on what their goals are, what their wishes are. Yes, we talk about death and dying, and we have counselors and we have staff that help with that as well. It is still hard to get to though sometimes for folks.
No, I hear you.
My favorite clients are ranchers because they live with death and dying on the ranch, and
that's earthiness, right?
It's more open. I mean, you right away. It's I don't want to linger. I'm ready to die, and that's what we.
No, and I still remember, and again, this is an anecdotal story, and folks, I apologize if this doesn't, but I remember my great aunt, when she was dying, I kept using the word, those that were interacting, passing or moving on, and she finally said, you know what, I'm dying, say the word, I'm dying. And it actually was sort of a releasing for people around to be able to talk more freely versus be so gentle that you actually minimize what was happening, if that makes sense.
Yeah, no, we tried to, when you don't want to push, especially in that first meeting with the admissions team, you kind of have to feel people out and see where they're at. And we try to use the words death and dying, not, past and expire and things like that, words like that. And we had, a lot of times we run in the same thing. We'll have the patient's daughter will say, well, don't say the word hospice. I don't want mom to know that you guys are here. Okay. And, but if she can read a name badge or she asks, we're going to be honest. And then we'll go meet the patient and she'll say, don't tell my daughter I'm dying. They're trying to protect each other. So we run into that, as well. So.
Any other questions before we start wrapping up here? We're at 1:40. We try to keep it to about 45 minutes, folks, out of respect for everyone's time. Because if not, there's two last questions, and I think not seeing any coming up on the monitor. I'm going to end with these two. One is obviously there's a lot of changes going on in healthcare throughout the country. Are there any challenges that you see on the horizon for hospice care in general? And I'm assuming that's a question of non-politics. You're just curious about what the ever-changing shape of healthcare. What looks like ahead for you?
I think, back to, I think we look at, will insurance, will Medicare, Medicaid, will they still be funded? Will hospice still be funded? I mean, we always, always a question. It doesn't matter Republican, Democrat, what the politics are. It's every year, is there going to be an increase or a decrease in reimbursements? Are they going to, not fund hospice? It hasn't been a problem.
And that's no different for you as it is for us as a Class B company that has some Medicaid part. Like you just kind of never know what the political shifts will be and how that'll impact it. So
yeah, the more frustrating thing always is crazy rules that get developed every year. So it's
more bureaucracy.
A physician go out every now for these face-to-faces that just started probably 4 or 5 years ago, and it's pretty pointless. I mean, our nurses go out and admit patients, and the first one we know who's eligible, but now we have to use a physician or nurse practitioner to say, yes, this person's eligible. So which costs a lot of money. Yes.
Now I saved this question for the last because I thought it was a great way to round it out. So thank you, who submitted it. They said, you seem like a very optimistic and bright person, yet you're around death and dying on a regular basis for 16 years. What is the joy that you found in this?
Oh, that is a good question. I think it is because of, we don't focus on the death and dying as much as we focus on, what can we do for this person to make their last time meaningful to them. And I think, and we don't do a lot of, we get creative here. If somebody took a 90-year-old guy skydiving, or guys on a horse, we try to do things, hey, what's important to you, and how do we, help this patient and family out through this difficult time. We have a creative agency. It's not know a lot. We don't say no a lot. We say, well, what's the third best answer? What can we do for them? So, this person's doing this treatment. Okay, but can we get creative and provide a service in a different way? So I think that's what's kept me here for sure.
Yeah.
Great people to
obviously 16 years, and you obviously struck a chord with some of our attendees today. And actually, I'm going to end with one more. She just put this up there. She just said, I want to thank all the hospice people that work in this industry. My mother is receiving hospice care, and all of their staff are wonderful, both my mother and our family. And so I think that's a kudos to you, Brian, and what you're doing, and more importantly, the spirit with which you're doing it is notable. So
thanks. I think you got anyone who does any type of care in the home with folks does wonderful work and has to enjoy it, or you won't do it long. I can tell you. It's hard work.
Well, with that brings us to the end of our May Community Connections, folks. And on behalf of People Care Health Services and all those that attended, Brian, we want to thank you for joining us today and sharing your own journey and your insights and answering our questions that ran the myriad from the personal to the professional to the political. And we're actually going to post online a link to this video, as well as the handouts that Brian provided earlier. If you are a People Care employee, those handouts were sent out via email to each agency and each department. If you're a People Care employee that's in the field or a client, you can contact our People Care offices, and they will be happy to forward those handouts on to you. Or you will be able to find them on the link on our website, www.peoplecarehs.com. Click on the Education tab, and you'll see another one that says Community Connections. There you'll find links to not only today's webinar with Brian and his handouts, but also many of our past presentations as well. Our next Community Connections will be Wednesday, June 14th at 1:00 p.m. We will be sending out invitations via email, voicemail blasts, as well as through our social media platforms. So be sure to like us on Facebook, as we're constantly updating and posting videos and helpful hints. With that said, again, Brian, thank you on behalf of People Care Health Services for spending time with us today. We wish you well in your continued endeavors.
Thanks, Todd. And if anybody has any other questions later, you can always email me those questions.
Perfect. With that,
thanks, Todd.
We will bring Community Connections to a close. Colorado Proud, Community Strong. On behalf of People Care Health Services, All of you have a good rest of your week. I'll be terminating the connection now.